Nursing 102 Lab. This is Jennifer Salyard talking to you. We're going to finish up on chapter 25. We had gone over the enteral already in the chapter. That's with the oral and the gut and stuff like that. Now we're going to go over the parenterals. Parental just means the parent of all injectables. So parental, for example, would be your intradermal, your subcutaneous, your intramuscular, your intrathecal, your intravenous. Those are types of parenteral, anything that's injectable. But before we do that, I wanted to answer some questions that I have been getting since the last week's lab, and maybe you had the same questions, so I want to go over them. So somebody had asked me what efficacy meant. I know you'll see that on your med cards. And efficacy simply means is to how effective a medication is dependent on the concentration once it's at the intended site it needs to reach. One example your book gives is nitrofurantoin, also known as macrobid. Nitrofurantoin is the generic name. It's a lowercase letter usually, and macrobid is the trade name, which the brand name, which is usually a capital letter. You know it's the trade name because it has a registered mark on it, a capital R with a circle around it up at the top. When there's two names, the brand name or trade name is actually the one that is capitalized and the generic is not capitalized. You'll have more than one brand name sometimes and only one generic name. You do not always have to have a brand name on a label. It can always be just the generic name. If there's only one name, it's the generic, and sometimes it's capitalized when there's only one. So back to what efficacy is. The example your book uses is nitrofurantoin, also known as macrobid. This drug treats and prevents urinary tract infections. What they're saying is that it is highly efficacy or highly effective because it's known to be highly soluble in urine and it concentrates in the bladder at the intended site where the infection is. Therefore, it's highly effective. When it's right at that site where it's intended to hit, that then and it breaks down there, that is a highly soluble or highly effective area or medication. So that's what that means. Some words I want you to keep in mind when we're talking about efficacy. We talked about first pass effect and bioavailability. First pass effect means that along the way it gets broken down in some areas. So it might have to go through like the stomach where the hydrochloric acid breaks it down, or the liver where the liver starts breaking it down. And then once it gets to its intended site, it's not 100% available or bioavailable to that tissue or organ for utilization. And that's why sometimes when you look at oral concentrations are higher than they are with injectables, because we know they don't have 100% bioavailability. Injectables like intravenous IV injectables are 100% bioavailable. They go straight through the bloodstream right to the target area, and it's 100% of the medication available to that target area. So that's what the first pass effect means and bioavailability means. So we know with macrodantin, it isn't always 100% bioavailable, but it's highly soluble and highly, it breaks down right where the site is, and so therefore it's highly effective. All right. The other question I had was pregnancy categories. They weren't sure what A, B, C, D, and X is that we went over. I was talking about teratogenic effects. X is a teratogenic effect, meaning it's a definite happening where the fetus is compromised somehow, some way, whether it be a physical deformity or a mental deformity or whatever that they end up with based off of taking a certain drug. Category A is at its safest, meaning that when they did their lab tests, or maybe they didn't do any lab testing at all, so they really don't know. They just know that there's no known fetal or breakdown or teratogenic effect. Where when we go closer down the scale of A, B, C, D, and X, we know have more higher fetal problems. So one medication I had mentioned to you before was a medication, if you recall, called thalidomide. And thalidomide was given to pregnant women for nausea and vomiting. And what it ended up doing is causing their babies to be flipper babies, we call them. Flipper babies born with like just maybe like a little appendage out of the shoulder area where the arm should be. And even their children were having children that had problems too. So that was highly teratogenic. So it's really important, like if they're breastfeeding and stuff like that, you should know what the category is of them, or if they're pregnant, what the category is, A, B, C, D, X of the medication. Let them know what that medications can do, any harm to the fetus. So sometimes the benefits outweigh the risks involved, and they need the medication anyway. And so mom or whoever, if they're on, can't sign, the next of kin or whatever will sign and say still give the medication, even though we know it's going to cause problems because we need mama to survive. So that's another medication. Another thing they asked. Some other things people asked were the differences between adverse effects and side effects. They said, John, we looked it up in the drug handbook, and we don't understand it, why they're separated. Isn't that the same thing? No, they're not the same thing. They're close, but they're not the same thing. Side effects are unintended, but they're predictable effects that we know medication generally will cause. Let me give you an example. Antihistamines is a category of drugs that we use for like allergies to help dry up secretions and stuff like that. Diphenhydramine or Benadryl will cause drying effects. That's a side effect. We don't want it. It's not intended for what we're using it for. Where our intentions are, yes, to dry it up, but not cause that dry sensation. But it's predictable. We know that happens in a lot of people because a lot of people have reported that. Where an adverse effect is usually more harmful. No, it's not intended also, but it is not predictable either. We've rarely seen this. Oh my, it happens, but it's very rare. It's not really a predictable thing. It's just maybe one person reported and they have to put it in there, because it happened. So that's what an adverse effect is. And you want to report all effects, of course, chart all effects and notify the physician. Especially, he might hurt you if you say they have dry eyes, if they're taking antihistamines. I'm talking something that's harmful to them. Okay, like, I don't know, hives or whatever. That's not good. Okay, the other thing they wanted to know, what was synergistic? What did idiosyncratic and drug incompatibilities mean? Synergistic drugs are an interaction when you have two or more drugs put together that they actually interact positively and give a boost to the client. Sometimes we do combine medications for that purposeful reasoning. An idiosyncratic effect or reaction is usually an unexpected, abnormal, or peculiar effect response that a medication has. I gave you, mine was promethazine, also known as Phenergan, is the brand name. It's for nausea, and I was given that, and it made me sicker. It made me feel like I had jumpy skin. I was very anxious, and never ever again will I ever take that medication. That is an idiosyncratic effect. It was intended for one thing, and I got a really crazy opposite effect. And then drug incompatibility. Drug incompatibility is when more than one drug is mixed together and it causes some kind of chemical deterioration. And then antagonistic drug interaction is when you put two or more drugs together and they're incompatible. They cause a interaction that's not what you wanted. Okay. All right, once we're done with that, I wanted to also talk then more about the pharmacokinetics of your medications. I did send you that paper that talked about pharmacokinetics and also gave you some videos to watch. One thing with pharmacokinetics is remember the mnemonic ADME, A-D-M-E, and I always say add me to your body and see what I do, because that's what pharmacokinetics is the action the drug has on your body. So with pharmacokinetics, absorption is the A in ADME, and that is simply when taken into the body, whether it be injectable, intranasal, oral, buccal, whatever. When taken into the body, the time it is to take it in to the time it gets to the bloodstream. That's absorption. Distribution, the D part of the ADME, is when the time it gets to the blood, to the time to the target area. So once it's in the blood, from the blood to the target area, the tissue or organ it intends to work on. And then M is metabolization, so broken down. Once the drug is at the target area, it's going to break down, be processed or utilized. And then E is excreted. How is it excreted? How did we get rid of the drug? Over the time, like with the half-life and all, how does that create is like when we excrete it. The half-lives are going to be longer in people with bad like livers and kidneys and all because they don't excrete as fast. But we can get rid of it in the kidney, the liver, respiratory or whatever. That's what excretion is. Okay. Next we have with pharmacokinetics, you want to factor in that there are things that happen that would change pharmacokinetics or affect the pharmacokinetics, the action it has on the body. Age is one of them. So with age, the smaller, with kids, they might need a smaller dose because their liver might be immature. They have smaller body masses than adults do. In the elderly, they also may need maybe some smaller dose of medication because their organs are starting to get damaged, shut down. They're slower to metabolize the medication, like your liver and the glomerulus, which is the filtration or the functioning unit of your kidney. It filters the urine and all. It slows down and causes poor excretion. And if you got to be careful with that when people have poor hearts and poor livers and poor kidneys and stuff like that, because it can build up in their system because it doesn't excrete quickly. And when we give more, it keeps building up and can cause a toxic effect. So you have to be very careful with that. So age does affect pharmacokinetics. Another thing that affects the pharmacokinetics is gender. We know that women have less fat and less muscle mass, or have more fat, and less muscle mass, and their hormones are different. And so those can play a role in the pharmacokinetics and how it interacts in the body. The environment can play a role in how it interacts with the body. We know heat and cold can either slow or speed up or slow down the peripheral circulation, and so it might take longer or go through faster. Timing of having food in your system versus not having food in your system. If you're dehydrated or if you're full of fluids, what the effects it has on the medication. So that can be another issue. And then even noisy environments. Noisy environments can be a problem where you might have a higher resistance to maybe some tranquilizers if you're anxious. That could be a problem. We know also timing of medications matters. For example, we manufacture cholesterol when dietary intake's at its lowest. And so with that knowledge, nurses have that understanding that some cholesterol reducing medications are better given at night. For example, your statin drugs like lovastatin and all those are better given at night because it'll target on when the time at night is when we make our cholesterol the most. Pathological states, we said, alter pharmacokinetics. We've already talked about kidney disease and all can change that. Your genetic factors can alter pharmacokinetics. For example, Asians metabolize some opioids like morphine and all more slowly than others. And then last, is your if you're pregnant, of course, it can cause teratogenic effects, and then psych factors. We have lots of studies out there where we didn't know the effects that they'd have on the medications, but some placebos, which are fake, not the real medicines given, and they've had the same positive effects as somebody that had the medication, the testing medication, which is really something that we need to study more into. So it is mind over matter. I know when we talk about tests and stuff like that, that I always say, think positive, and you're like, wow, that's not going to help. Well, if you didn't study right, it's probably not going to help. But it doesn't help either to be negative. If you think positive and you relax, and in reality, you can pass a test. If you studied, negativity is not going to help you. It's mind over matter. It's been proven to think positive, you do better on your test. So we want to always keep in mind that we can succeed in all situations, and you can pass that test. And just like medications, if we think something's going to be helpful and we didn't know that it was a fake medication, it's showing that it can. So like if you're anxious, for example, I told you it can increase the resistance to a tranquilizer. If you're more relaxed, it'll be better for you. Okay. All right. With that in mind, then I want to get back into the injectables now. The parenteral, which is the parent of all injections. That's the umbrella word that all those injectables I mentioned, like intravenous, intramuscular, and all, are under. If you go to page 805, table 25-6 for my group, I need you to know this table. Know that the smaller the gauge, the bigger the needle. Or you can think of the bigger the needle, the smaller the gauge, whatever works for you. So, for example, on the routes, you need to know that intradermal is given at an angle of 5 to 15 degrees. It's given in the site of an inner aspect of the forearm usually, and you would give a maximum dose of only 1/10 of a milliliter. The needle gauge is going to be larger because they want it to be a smaller needle, so it's going to be about a 26 to 28 gauge. I know when we give insulin, it's an even smaller needle because we're tired of getting pregnant. It hurts a lot, and those smaller, thinner needles are so much less painful, and we usually use about a 28 to 31 degree angle, but that's given sub-Q. You need to know the needle length for an adult only. You can do the infants when you get into the pediatric, but just know that infants are small and you should always check. And then you should know how much I told you, like, the maximum amount you can give in. Now, another thing in your wonderful book, which I really love, that they gave you pictures, because these pictures are fantabulous, is with syringes and stuff, we have to make sure that with a 1 milliliter syringe, also known as a tuberculin syringe, they're usually pediatric dosage uses. They're more accurate. We will measure them. We'll round them to the nearest 100th when we're doing our rounding. Where anything like a 3 milliliter or higher, it's always rounding to the nearest 10th. When we give heparin, it's given in a tuberculin syringe, the 1 ml syringe. When we're given insulin, insulin is only given in an insulin syringe. And I'm saying these two meds particularly because they're measured in units usually. And you'll see that the insulin is given by the units, and heparin is units, but we measure it in milliliters, and you'll learn that with your dimensional analysis. Now, back on when you go to page 810, there's some great pictures. Figure 25-22 talks about the sites commonly used for intradermal. And on page 811 and figure 25-24, it shows you the sites commonly used for subcutaneous. The reason why I need you to know those sites is because you want to make sure you're getting in the point where you should. And then also, it does a good job at showing you angles. So if you don't know what a 5 to 15 degree angle is, it's okay. Because on page 810, figure 25-23 is going to show you what a 5 to 15 degree angle is. Amazing, right? All right. So back to page 805. Let's start with the intradermal needles. When we're giving an intradermal needle, it's just within, it means that dermal layer right above, underneath the skin. So when you're giving it, remember maximum dose is about a 1/10 of a milliliter. And usually we give intradermal injections with allergy injections and when we're giving TB skin tests. You're going to just slightly place always angle up, but the angle up on the syringes, and then, which I showed you in the lab last time, just go slightly under the skin, pull up a little bit, and you're going to push in the medications, and it should create what we call a wheal, W-H-E-A-L, if you did it correctly. And you'd want to make sure you don't rub that wheal afterwards or place a Band-Aid over it. It might bleed a little bit. You can dab, but leave it alone. You're not going to bleed to death on it unless you're on some major, like, blood thinning, walking time bomb for it. Okay, the next thing, and remember it's at a 5 to 15 degree, is the subcutaneous. Insulins are given subcutaneous. There's heparin is sometimes given subcutaneous. So those type, you want to make sure you know where to give it. I always rotate sites in the hospital. So I am giving my own insulin. It'll be in my thigh and my belly because I can reach those. I can't reach it sometimes in the back of my arms very good. I can't pinch to and then with one hand because it's my own hand. And I'm just not that good, and give it with the other. So in the hospitals, I try to give them in sites where they can't reach, so I can make sure that they have a good rotation of sites. It's good to rotate sites because it can cause like a lipodystrophy or an uneven area where your skin gets lumpy and hard and can actually get cellulitis. So we always say rotate sites. With subcutaneous, when we're giving insulin, we tell athletes to always bring a snack with them and don't give the insulin in the thigh when they're going to be running or walking because it can actually absorb quicker. And so they have to be very careful. I usually give it in my abdomen because that's the quickest absorption site. I mean, it's a better absorption site for us. And that's why I do that. It's usually about 1 to 2 inches away from the umbilicus, and you can see that picture on that. And you always want to rub it with alcohol first around that site, let it dry. With subcutaneous, you're going to pinch the skin. And if you can pinch more than 1 inch, I always say, you're going to give it at a 90-degree angle to ensure that you are injecting it into the subcutaneous fat. And if they're thinner build, it's going to be a 45-degree angle. And just look where you're going. Of course, you don't want to put any surgical sites or anything like that. I try not to go into like tattooed areas and stuff because if I'm going to see a reaction, I want to see it on the bare skin if you can. Sometimes we can't. All right, and we only give a maximum amount for our subcutaneous is usually about, if it's in other areas of it, like half to about even 1 milliliter of medication. All right, intramuscular is another one. IM, there's different sites for IM. There is the good old deltoid. We have the gluteal, which we don't really recommend anymore in the back end. We have the vastus lateralis, and we have the ventral gluteal. The one site that we recommend a lot, and with adults especially and all, is the ventral gluteal. And the vastus lateralis is one that we give for people with all ages. The vastus lateralis, though, is definitely given to infants that are not walking yet. So usually the rule of thumb is like 7 months or less. But if they're not walking, give it in the thigh. That's the vastus lateralis. With the deltoid, look on the lookout for, you want to have a nice fatty area. If they're not so fat, you want to use, of course, a length of a needle that fits them. Some need perhaps maybe a 1 inch, where a bigger adult would, a chunkier adult, I should say, would need like about a 1.5 inch, because you want to make sure you get into the muscle. Some medications have to go deeper intramuscular, and with those medications, we use a Z-track method. And so for a Z-track method, let me try, we want to make sure the skin will trap over after we give the injection so it doesn't leak out into the tissue. Iron is a very harsh medication on your skin. It can stain it permanently. We give those medications that are more caustic and problematic and have to be deeper. I am a Z-track method. So with one hand, we'll stretch the skin and hold it taut throughout the whole procedure. While holding that back, just push it across, back. We will inject the medication, so we'll put the needle in, inject it, hold it for about 7 to 10 seconds, usually 10 seconds, pull it out, and then let go of your skin, and that'll trap it over top of it. I used to do it where, like a Z, I'd pull it, one way and then the other, give the medication, hold it, and then let it go. But your book shows just to slide it over, and that's what you should do. Alrighty, so if you're trying to figure out how to measure or where to measure with your injections, once again, your wonderful book has great instructions on there and pictures, which I really, really, really like. Love, love, love this. So starting on page 865, you'll go to procedure 25-13A. It has the ventral gluteal site. Remember, this is the one that we said it's a safe site for IM administration because it's not in any proximity to any major blood vessels or nerves. Like the gluteal used to be like in the back end. Yeah, it's a nice muscle meaty area, but generally, and I say that sometimes for deep, the sciatic nerve can be affected, so that's why we don't use it much anymore, recommend it. But this ventral glute area, yes, we do recommend it. And like I said, you're going to want to know your location mark. So read, you're going to place your hand, your palm of your hand at the bottom on the greater trochanter, which is like right up at that top, that where the femoral head is. You're going to then, if you're doing it on, have them lay sideways. Place your, like I said, your palm on the greater trochanter. If you're doing it on the right side, you're going to use your left hand. On the left side, you're going to use your right hand. And the idea is because when you stretch your finger, you have it right here on the thing, and then you let your finger out, it should be pointing to the belly button, the umbilicus area up to that. So on the greater trochanter goes your palm, your index finger on your anterior superior iliac spine, and your middle finger pointing towards the iliac crest, making that V, that triangle, and in between that triangle is a sweet spot where you will inject. I don't know if I can try to turn that for you to look, but as you can see, there's where your greater trochanter is. Okay, hopefully you saw that. Now on page 866 is the deltoid area. This is where you're going to look for the acromion process. That is that bone up at the top of the shoulder here. You're going to locate that, of course, and you're going to place your hand on there. Your finger, your index finger should be on that the acromion process, 2 fingers down, and then of course you create a, usually with your thumb on the other side, but I'm using my hand on the shoulder, is you're going to put like a nice triangle effect, and that triangle is the sweet spot where you put the injection at. The other one is the vastus lateralis site, and that is a lying position. This is also, like I said, great for all ages. Sometimes we'll put it in combative people because it's easier to hold their legs down sometimes than their arms. And we'll locate the greater trochanter in the lateral femoral condyle. So the femoral condyle, where the femoral area is, we'll place our upper hand on that one, and then where the lateral femoral condyle is we put our upper hand, like I said, the other one's on the greater trochanter. We'll put our lower hand above the knee usually, and on that outer part, the lateral side on the outer aspect is where you have like an imaginary rectangle where your lower hand, your upper hand's the smaller part of the rectangle, and the longer is your imaginary line, and that's where the sweet spot is. And hopefully when I turn this around, you'll be able to see that too. Okay, so that is the vastus lateralis, and you should know that as well. Okay. And they have, like, for videos, it has Davis's nursing skill videos. You can look those videos up, and along with some questions in there are available on Davis, just in case you were looking for some questions. All right. Now I want to give you some questions real quick on, just so, and make sure you answer them and send them to me on the question site. The first one that I'm going to give you is, there's 5 questions. The primary care provider prescribes furosemide with a lowercase f. Furosemide. That's generic name for Lasix. So it prescribes furosemide with a lowercase f, 40 milligrams IV for a patient with heart failure. Which drug name is used in this prescription? Is it A, chemical, B, brand, C, trade, or D, generic? Okay. That's the first question I wanted to ask you. Let me get over here, mess with this a little bit. Hello. I can kind of record sometimes, but I know this one will record this time. and you'll get it. Okay, next one is, what term refers to the movement of a drug from the site of administration to the bloodstream? What term refers to the movement of a drug from the actual site of administering to the bloodstream? Is it A, absorption, B, distribution, C, metabolism, or D, excretion? Moving along. A client who just returned from the anesthesia unit after surgery complains of pain, severe pain. Which drug contained in the medication administration record will we offer as for the fastest relief? Would it be A, liquid acetaminophen, which is Tylenol with codeine? So liquid Tylenol with codeine. B, IV morphine sulfate. C, intramuscular or IM meperidine, which is Demerol. Or D, oral oxycodone tablets. Which one would be giving the fastest relief? Okay. After receiving diphenhydramine, which is Benadryl, a client complains of having a dry mouth. Which drug effect is this client experiencing? A, side effect. B, adverse reaction. C, toxic reaction. Or D, supportive effect. So after receiving Benadryl, also known as diphenhydramine, a client complains of having a dry mouth. Which drug effect is this person experiencing? A, side effect. B, adverse reaction. C, toxic reaction. Or D, supportive effect. Okay. And then the last one is, lab test results indicate that warfarin, also known as Coumadin, an anticoagulant therapy, one we check the PT and INR on in labs, which is normally supposed to be 2 to 3 if you're taking this medication, is suddenly ineffective in a client who has been taking the drug for an extended time. The nurse suspects an interaction with herbal medication the client has been taking on their own. What type of interaction does the nurse suspect? Would it be A, antagonistic drug interaction, B, synergistic drug interaction, C, idiosyncratic reaction, or D, drug incompatibility? Which one would it be? Okay, well, that was the questions I had for you, so you're going to want to look those up and answer them. I'll let you know if you're right once you've turned those in, and we're going to move along on our injectable. Now, I just want to get those in. And don't forget, you're going to have an assignment that I'm going to email or put on Canvas for you guys.